Hi everyone, it's Dr. Williams. We're going to spend some time discussing eye and vision disorders in pediatric patients. I need, while we're moving through this PowerPoint, for you to pay close attention to things I have highlighted or bolded or made a different color, put asterisks by, things I've emphasized as we move through each slide. This will serve as your study guide for your upcoming exam. So first we're going to talk about eye screening, visual normalities and abnormalities. The biggest thing you need to know when you're seeing pediatric patients is what's normal and what's abnormal. And a big thing that you're going to see as we move through every type of disorder this semester is that milestones are a big thing in newborns, infants, and children, because that's how we tell if there is a deficiency usually, okay? Your developmental milestones are very important to know, and I know that's hard to remember all of them, but there are some big ones, especially in pediatric vision screenings. If by 2 to 4 weeks they're not able to at least sporadically fix and follow on an object, that's a red flag. You need to watch that a little more closely. If by 4 months they're not able to fix and follow and really, turn their head to look and follow objects all the time, that's a big red flag. Okay. Um, that's going to be one that you need to refer to ophthalmology or to some, pediatric eye specialist. Most ophthalmologists see babies, children, all the way through adults. So you need to refer that. And that's a big thing of who needs to be referred and who doesn't. Okay. There are a lot of different recommendations out there. Healthy People 2030 have some pediatric focused vision objectives that I want you to look at. You may use some of these in your SOAP notes for your Healthy People 2030 goals. Okay, they really, the biggest push from Healthy People is early diagnosis and treatment of eye disorders in children. Okay, then if you read your book under standards for visual screening and care, there are a lot of different um, people basically that are recommending when screening should be done. But basically, they all say screening needs to be done between 6 months and 5 months. Um, Internal and external inspection of the eye, check their ocular mobility, and then between 18 months and 5 years of age, that's when you're going to start using the instrument-based screenings for things like amblyopia, high refractive errors, and strabismus. Okay, so that's something that's important to know. At birth, eye development is incomplete. Okay, but again, by 2 to 4 weeks, infants can fix and follow objects to midline at least sporadically. Okay, they'll have reaction to changes in light even as newborns, but they do keep their eyes closed most of the time. Okay, they can see. Some people think that they can't see, they just can't see very far, maybe 3 to 6 inches, and they can see bright colors or color changing. Okay, if you look on page 457, table 30.2 kind of gives you the visual acuity norms. I'm not going to test you on specifics of that, but you do need to know that when they're born, they have very poor vision, but they can see, and then slowly it gets better and better. And usually by the time they're 18 to 24 months, they have what we would call normal vision, which is 20/20 or 20/25, somewhere around there. Okay. Um, at about 4 months, they should be able to recognize familiar things, familiar people. And through all of this, newborns, infants, they should be able to recognize and turn towards their parents' voices or familiar voices. They don't produce tears with crying until they're 1 to 3 months of age. So if you have a mom or a dad or caregiver bring a child in that's 2 months and they think it's abnormal for them to not have tears when they're crying, that's normal. Okay, some develop a little bit later, but by 3 months of age, they should be producing tears. Okay, and again, I'm not going to test you on specific visual acuity norms or the A and P of the eyes. You just need to know, okay, by 4 months, this child should be able to fix and follow. As newborns, they will have changes or reactions to changes of light, things like that. The big milestones that are going to be pretty evident for you to look for.
This is just a brief overview of the landmarks of the eye. You should know where most of these are. They do not change between pediatric and adult patients.
I'm not going to go too much in detail on the anatomy and physiology of the eye. It doesn't really change a whole lot from newborns to infants to adults. You do need to know where the cornea is, the optic nerve, conjunctiva, sclera, pupil, retina, because you're going to be looking at these, especially as we move through the disorders or the problems. You need to know what part of the eye each problem is affecting. So next we'll move into assessment. This is extremely important when you're talking about the eye. Again, history is crucial to being able to diagnose. Okay, have they had eye injuries? Do they already wear prescription glasses or contacts? Do they use sunglasses when they're outside? Do they have a history of double vision? Have they had a concussion? Were they premature? Premature babies that are especially on high oxygen levels can have retinopathy of prematurity and decreased visual acuity when they get a little bit older. So that's important to know. Eye examination should be a routine portion of screening, starting from newborn all the way through elementary, junior high, high school. And a lot of schools now in Rapides Parish, I don't know about other parishes, but our kids are screened at school. And you'll get a note home from the nurse that says, this is what the screening showed. It was abnormal, etc. They'll also test their hearing in school a lot of times, okay? Big thing is knowing where everything is in the eye, how to obtain that good history to be able to diagnose and see symptoms of eye disorders. If you look on page 459, it kind of goes into the physical examination of the eye, and that's important to look at. There's gross inspection. You need to elicit the red reflex. Just like in adults, a fundoscopic exam is usually greater than 5 years of age. You don't want to start that too early because they're not going to be very cooperative, okay? You also need to watch their growth parameters, okay? Their head circumference is a big thing. It's going to be checked at every pediatric appointment, especially well visits. So that's something that is important to know. If you look on page 458, table 30.3, it goes through the ages and methods for pediatric eye evaluations. Again, I'm not going to test you on specifics like at 3 years, they should have 20/50 or worse vision, things like that. You just need to know that it gets better. And there's also on that table indications for referral. That's the important part of this. Who do we need to refer? So if you have a patient that is 4 weeks old and they have an abnormal or asymmetric red reflex, that needs to be referred, okay? You have somebody that at 5, 6 months can't fix and follow, refer. Anybody with an asymmetric corneal light reflex by 6 to 12 months, refer. If they're greater than 3 years and they have very, very poor vision, you need to refer them, because by 3 to 4 years, they should be 20/50, 20/40, moving to that normal range. So if you test someone and their vision is 2200 and they're 4, you probably need to refer that patient out, okay? If you see any structural abnormalities in any patient, it doesn't matter if they're newborn all the way through adulthood, senility, that needs to be referred, okay? You need to inspect the internal and external structures of the eye. You need to evert the eyelids and look for foreign bodies. And again, that growth parameter is important. Some symptoms of eye dysfunction include vision loss or abrupt vision change in older children, blurring, double vision, spots, floaters can also happen. Younger children will usually have problems fixing and following. They'll squint a lot. They have a head tilt. They may have abnormal hand-eye coordination. They may also have a balance or gait dysfunction that you need to look for. They can have photophobia, any physical issues where they're having swelling, drainage, redness, erythema, pruritus, anything like that should clue you in that something is wrong. If they constantly blink, that can also be a sign. We all normally blink several times a minute, but you see someone that's blinking 10 times a second, there may be a problem there that you need to look at. So for this one, the most important thing I want you to take away is, when do you examine a child's eyes? When do you test a child's vision? Okay, it's very important for an accurate exam. You do not want the child to be irritable, anxious, hungry, tired, anything that's going to make them uncooperative. Okay, it needs to be a calm, quiet environment. If you can turn the lights down in the room, that's even better. The child needs to feel comfortable with you. Maybe have them sit on the parent's lap. Whatever makes them most comfortable is the best way to do this. Okay, you have to gain their trust when you're looking in their eyes. And a lot of times you can play games with them, and when you bring out your otoscope with the light on, they love it. So let them play with it for a little bit before you start looking in their eyes, ears, nose, and throat, so that they are more comfortable with you doing those things. The eyes, they're usually not as uncooperative as they are with the ears and throat, but they don't really want you touching their eyes too much. And then some babies don't want anybody touching them, period, except their parents. Okay. So of course, we've kind of talked about this, the red reflex testing, visual acuity. You can read in your book when color vision needs to be tested, peripheral vision, ocular mobility and alignment. You need to assess for vision loss. That's a big thing. Diagnostic testing. Is that something the nurse practitioner should be doing? If you aren't comfortable, trained, and ready to do those tests, no, you shouldn't be doing it. Send them to an ophthalmologist or an optometrist, okay? Never be afraid to refer a patient to a specialist if you're worried about something. So next we'll talk about ophthalmic medications. There's a lot of different types. There's antibiotics, corticosteroids, decongestants, antihistamines that are topical, etc. If you're not comfortable prescribing these, then don't. Okay. If you have a patient that has conjunctivitis, you should be comfortable prescribing an antibiotic eye drop. Okay. So you need to know those. And as we move through the disorders, I'll point out, what is important for you to know. We also need to keep in mind, as family practice providers, primary care providers, that there are a lot of drugs that can cause adverse ocular side effects. Okay. There's some antibiotics that can cause retinal hemorrhaging. There's corticosteroids that can cause cataracts and increased IOP. So if you have a patient that has been on steroids for prolonged periods of time, they're more at risk for cataracts and increased intraocular pressure. Okay. Digoxin can cause vision problems. There's a lot of them, and it's on table 30.5 on page 465. Page 464, I'm sorry. That's important to know, okay? We also need to educate on prevention of eye injuries. Sunglasses or protective glasses that they need to wear during sports and things. Laser pointers are also something that needs to be discussed with parents. Screen time is a big one. Prolonged screen time can cause decreased visual acuity. And if you look on page 465, you'll see the acronym SCREENS, and it stands for screen limits. There needs to be a limit of how much screen time the patient can have. Comfort. Screens should be at eye level and at least 25 inches from the eyes. rest. Children should take frequent rest breaks while watching anything, and that includes at school, at home, playing games. It doesn't matter what it is. Eye drops, if it leads to dry eyes, over-the-counter eye lubricants should be used. You don't want someone to have chronic dry eyes because it can cause them to rub their eyes a lot and lead to corneal abrasions, etc. Exit outside. They need exposure to sunlight. They need physical activity. They need to be away from the screen. Okay. No nighttime screens before they go to sleep. They should not be on the tablet, iPad, computer, TV, whatever it is. Let their eyes rest before they go to bed. And then screen settings. There should be settings on pretty much all iPads and tablets have it where you can set the screen brightness. They need to monitor that. This is a major teaching point for parents, especially younger parents. They may not know how dangerous prolonged screen time can be. So we need to start that at the newborn period, teaching parents all the way through, high school. And at that point, you need to be teaching the parent and the child. Okay, so that's a major teaching point. And as primary care providers, one of our biggest roles, and I've said this every semester, is education, education, education. So you need to start that young and continue it. Going through a little bit more of the abnormalities and what you need to look for. So, of course, you should always be assessing the red reflex. Okay, should be tested at every well visit. This can detect strabismus, cataracts, retinoblastoma. You need to have a darker exam room, which I said earlier. Stand at an arm's length from the patient. You want to set the light on your ophthalmoscope between 0 and 1 to illuminate the face. Look at both pupils simultaneously and separately. Okay, children with fair skin should have a brighter reddish orange red reflex. Those with darker skin may have a pale appearing or dark red brown red reflex. It should be symmetric. Okay, if there's any asymmetry, if you see dark or white spots, opacities, leukocoria, all of that should prompt you to refer them to an ophthalmologist. And that's what I want you to take away from this slide is, what do you refer? Okay, asymmetry, dark white spots, opacities, a white pupillary reflex, which is the leukocoria, needs to be referred immediately to ophthalmology. Okay. All right, next we're going to move into some of the visual abnormalities, refractive and visual. The refractive errors that we're going to talk about are the hyperopia, which is farsightedness. That's when they can see objects far away, but they can't see close up. Okay. Then you have myopia, which is they can see close up, but they can't see far away. Okay. Then we move to an astigmatism, which is where the cornea or the lens is uneven and they can't focus light from an object no matter what. If it's far away, close up, it makes it blurry. You can also have a patient describe kind of lines coming off of lights, especially at night. People with an astigmatism tend to have trouble driving at night because of these refractive errors. And then you have anisometropia, which is where each eye has a combination of refractive errors. Okay, so they may have nearsightedness and an astigmatism, etc. And box 30.2 on page 466 describe those, so you need to look that over. It also goes into the definitions of visual impairment. So you can have legal blindness or low vision. Low vision is between 20/70 and 20/200 range. Legal blindness is over that 20/200 range. Okay. Again, clinical findings that's going to cue you into something is wrong is going to be, excessive squinting when they're trying to look at something, fatigue, they have a lot of headaches, pain in or around the eyes, etc. I'll tell a personal story. I've always had really poor vision. And when I was in, kindergarten, first grade, we didn't know, but I had to sit at the front of the classroom and I would have to squint to see the board, even at the front of the classroom. And my teacher caught that and was like, okay, why are you having to squint to see? It made things clear. So go to the pediatrician. At that point, my mom had no idea that that was a sign of poor vision. So I've been in glasses or contacts since grade 1, and that was the first sign that anyone caught on to, was me sitting in the front and squinting to be able to see clearly. Okay. A lot of headaches. If you have a child that's complaining of headaches every day, especially during the school year or when they're on tablets a lot, have their eyes checked. We need to start this early with their eyes. Both of my children need glasses, and it was because I had them screened young, and both have needed glasses. So we need to educate parents that screenings for vision are very important. Okay. If there's going to be, if you notice some kind of abnormality, whether it's a refractive error that we talked about in one of those 4, or a visual abnormality, refer. Okay. And then next we'll move into more of the visual abnormalities: amblyopia, strabismus, which is where there's a defect in the alignment. So they develop what's called a lazy eye. Okay. One eye is working normally, quote unquote. The other eye kind of either lags when they're looking a certain way, or you may see medial deviation where it moves in towards the eye, or lateral deviation where it kind of tends to go outside. Nystagmus is, we describe that as like the shaking of the eye, especially when they try to focus on something. It can be in one or both eyes. It can be horizontal, vertical, rotary, or mixed. It can be congenital or acquired. Something you need to look for. Cataracts. If you look on page 468, it tells you what to look for. And basically, it's an opacity of the lens. It can be unilateral or bilateral. Either way, if you see it, you need to refer the patient out. Glaucoma. Not something that's very common to be seen in children, but it can happen. Okay. And that's, they'll have an increased intraocular pressure if a patient comes to you, and this is probably going to be a child or an older child, not really an infant. If they have increased tearing, photophobia, and excessive blinking, they need to be checked for glaucoma. Again, you're going to refer that patient out. I do want you to read through pages 466 to 468 where it talks about strabismus and nystagmus, because those are things you will see. So look at that. Other eye disorders are retinopathy of prematurity. It's just because they were born very early, so they didn't have full development of different parts of the eye, or babies who have really low birth weight, baby that has a prolonged exposure to high oxygen supplementation in the NICU. Fortunately, we have a lot of developmental clinic screenings. If you have a child that's in the NICU, they usually set that up to where these things are screened for regularly after they are discharged from the NICU. I have twins. One of them was a NICU baby. They screened her in the NICU, and then when she was discharged, she had regular screening for retinopathy of prematurity, visual deformities, etc. So it may not be something you diagnose, but you may have a patient that you're seeing with a history of retinopathy of prematurity. So you need to be familiar with it. Likely they're going to have an ophthalmologist that is treating that. They're going to need glasses young. Some of them are, still babies when they need their glasses. And then retinoblastoma, you need to look for specific things that clue you in on the retinopathy of retinoblastoma. This is on page 470. You're going to find that they have the unilateral or bilateral leukocoria, which is usually what is seen first. And a lot of times you'll see it on pictures. If you have a flash on a camera, it can rebound off of there. When you go to look into their eyes, you're going to see the leukocoria. They can have decreased visual acuity, an abnormal red reflex, nystagmus, cellulitis, photophobia, and then signs of global rupture are also possible. Again, if you see that leukocoria, you need to refer. Okay, it's the most common tumor in childhood. You need to know what to look for. You're likely not going to be treating this unless you work in an ophthalmology office, but you need to know what to look for and be prepared for referral, okay? Move into different eye infections. There may be more in your book. These are the ones we're going to focus on. These are the ones that you're going to be tested on in this course. There are others that may be important that you may see on boards, but usually these are the big things. These are what you're going to see in a primary care practice, in a primary pediatric practice, etc. So we're going to discuss the different causes of conjunctivitis, blepharitis, hordeolium, and the chalazion. Okay, next we're going to move into the different types of conjunctivitis. I made this table for you to have easier studying of conjunctivitis because there's a lot of different types. The most important things you need to know are the row that say etiology, symptoms, and physical exam findings, and treatment. I'm not going to test you on exactly what you're going to see on a PCR, etc. Okay, I want you to know what causes it. If I've pointed out when it happens, you need to know that. Physical exam findings, what is going to be complained about from the patient, mother, caregiver, whoever brings them to the doctor, and how are you going to treat it. So the table on page 472, table 30.6, goes a lot more in depth into a lot of these. The main thing I want you to pull from the management or from the table is the management portion. And I've kind of broken it down to make it a little easier on this table, but you do need to read through the management in table 30.6, okay? So newborn conjunctivitis, they're usually born to mothers with chlamydia, staph infection, or herpes simplex. Again, it's newborn, so it's in neonates. The symptoms and physical exam findings depends on what the cause of it is, okay? But the most common symptoms, physical exam findings, are going to be swelling around the eyes, redness of the eyes, and purulent discharge. And you're going to see a lot of these are the same for every type of conjunctivitis because the title tells you that redness, swelling, and inflammation is what conjunctivitis is. Pretty much all types of conjunctivitis are going to have discharge, okay? Treatment, you're going to irrigate. If it's gonorrhea, you're going to give Rocepin. You're going to use amycin for chlamydia and antivirals for herpes simplex. Inclusion is usually in neonates 5 to 14 days old and in sexually active teens, usually caused by chlamydia. Again, erythema, mucopurulent discharge, and a follicular reaction can happen. Treatment is going to be amycin in neonates, and then adolescents, you're going to use a doxy or azithromycin, erythromycin, or Levaquin PO. Bacterial, we've all either experienced bacterial conjunctivitis or at least have seen it, and you can have bacterial conjunctivitis and chronic bacterial conjunctivitis. Okay, so most common causes of bacterial are the H. influenza, strep pneumonia, staph, chlamydia. You're going to see it more in neonates between 5 to 14 days old, and that's usually they're born to a mother that has chlamydia. And chronic is more in school-age children and teens. Again, erythema, mucopurulent discharge, matted eyelashes. It's going to be worse in the winter for this one. And then treatments, it depends on if it's acute or chronic. Chronic, you're going to refer to ophthalmology if it is not cleared up with ophthalmic ointments, etc. So treatment is going to include erythromycin ointment. If they're older than a year old, you're going to use a fluoroquinolone. If they also have acute otitis media, you need to treat the otitis media also. Okay, they can use warm soaks to the eyes. They don't need to share towels or pillows, and they don't need to go back to school until they're able to start treatment. Okay, and again, if it's chronic, refer for ophthalmology treatment. And then you have trachoma, which is mainly caused by chlamydia, usually happens between 4 to 6 years of age. It's very rare. It can lead to scarring and blindness. And you're going to use Zithromax to treat that. Okay, viral is usually caused by the adenovirus, herpes simplex, or varicella. There's not a specific age range. Anyone can get it. It's viral. They're going to have same thing, erythema, excessive tearing. It's usually they have unilateral photophobia, fever, etc. Culture is the best way to diagnose it. If it's herpes simplex, you need to refer. If they have photophobia, refer. They can use cool compresses 3 or 4 times a day. Allergic conjunctivitis. This is usually in atopic patients, which we're going to get to a little bit later, but atopy is a triad of asthma, allergic rhinitis, and eczema. So allergic conjunctivitis usually affects those patients more than anybody else. It is seasonal, just like with all other allergies. It's going to happen in different seasons. They can have stringy, mucopurulent discharge, swelling, itching is the big thing. Okay, most of the others do not have a lot of itching, but allergic conjunctivitis, you'll see itching. They'll have a lot of tearing. They can have headaches, usually associated with rhinitis also. Okay, you're going to treat that with allergy medications, mast cell stabilizers, and refer to allergists if they need that, and a lot of them they do, so that you can pinpoint what is the cause and what are the precipitants of the allergies. It goes into heavy detail on page 475 of the different treatment options for allergic conjunctivitis. Big thing is prevention. Avoid allergens. That's what you need. Mild cases, just something for the dry eyes, artificial tears. An antihistamine decongestant is more effective than using just an antihistamine or a decongestant, but that would help. Okay. Topical allergic medications such as the cromolyn sodium or some of the others, but that's going to be allergy medications more than anything. Very common eye infections are blepharitis, hordeolium, and chalazion, and these all go together because they have similar symptoms. So you need to know the difference between the three. And on the next slide, I put some pictures to differentiate what you're going to see with those. Again, just like with conjunctivitis, most important is what are they going to complain about, what causes it, what are you going to see on physical exam, and how you're going to treat it. Okay, so blepharitis is acute or chronic inflammation of the eyelash follicles. It's usually bilateral. You're going to see a lot of swelling, erythema of the eyelid margins. You're going to see flaky, scaly debris over the eyelid margins on awakening. So when they wake up, they're going to have kind of flakes falling off their eyes. They can have a gritty, burning sensation in the eyes. You're also going to see mild conjunctival injection, which is red eyes. They need to clean their eyelids with a cotton-tipped applicator or a clean washcloth with some kind of no-tear shampoo, a very weak, mild shampoo. They can use warm compresses. Lid massaging can help. And then if they need medication, bacitracin or erythromycin ointment is good to use. And basically any anti-staph antibiotic, but bacitracin and erythromycin are the most commonly used, and they're going to do that once a day at bedtime until the symptoms subside. You're going to also, if there's associated seborrhea or psoriasis, eczema, or allergies, you're going to treat that also. No contact lenses. They need to wear their eyeglasses until this heals, and as long as they're on treatment, they do not need to have contacts in their eyes. You can have chronic blepharitis, and that's going to be treated with oral antibiotics. You're likely going to send those to ophthalmology, though. If you treat it initially with ointment, it doesn't clear up, go ahead and send them for further evaluation. The next is going to be the hordeolium, or a stye is what we know it by, but this is infection of either the sebaceous glands, the eyelids, or the meibomian glands of the eyelid. Okay, it's most commonly caused by staph or Pseudomonas. Staph is the most common. You're going to have tender red swollen furuncles on the eye. It can be external or internal. The patient's going to complain of a foreign body sensation. It usually ruptures spontaneously. They can use warm, moist compresses. They need good eye hygiene. Clean their eyes, not with their fingers, but with a clean washcloth or cotton tip applicator, etc. Antibiotic ointment if needed. Most of the time, you don't need treatment, but again, erythromycin can be effective if it's not healing fast enough for the patient. Steroids are not indicated for treatment of this, and they may need referral for an IND if it does not rupture on its own after coming to a point. So you'll see when it first starts, it's like a pimple. When it first starts, it's kind of red, swollen, and then it'll form a head, and at that point, it should rupture out, on its own. If it does rupture, they need to keep the area clean. Don't rub with their hands a whole lot. You're just introducing more bacteria and infection in there. So then we move to the chalazion, and that's a chronic sterile inflammation of the eyelid, and they're going to have a lipogranuloma or blockage of the meibomian glands, and that's usually on the posterior margins of the eyelids. These are deeper than hordeolums, and it actually could start as an internal hordeolum that has turned into a chalazion. But basically, this is chronic inflammation of the eyelid. They're going to have mild erythema and swelling that resolves in a few days, but then after the swelling and erythema resolved, they're going to have a round painless mass. Okay, and again, your book has pictures, and so does the next slide. Okay, they need hot compresses. They may need an IND if it persists or if it becomes a cosmetic concern. Put some pictures on here. The top left is someone with blepharitis. The bottom left is the comparison of a normal healthy eye to an eye with blepharitis, and then the yellow picture kind of goes into more detail of the difference between a chalazion and a stye. The injured eye, it's important to be familiar with these. Children are very accident prone. Teenagers are very accident prone, especially if you have someone that plays contact sports, etc. You're probably going to see this. So we'll start with the subconjunctival hemorrhage. Usually happens in neonates. It's spontaneous or secondary to increased intrathoracic pressure, such as excessive coughing, vomiting. It's usually painless, resolves on its own. You don't need to treat. If it's painful, if they have any vision loss or photophobia, obviously you need to refer. And that's with anything to do with the eyes. If they have photophobia, really bad pain or vision loss, refer. A black eye, we know what that is. It's usually a result of blunt injury. They don't need treatment. Again, refer if increased pain or swelling. If they have raccoon eyes, which is a dark color under both eyes, they may have had some kind of brain injury or head injury that you need to refer. Corneal abrasion is damage to the cornea, usually caused by scratching, rubbing. They get a foreign body in their eye and they constantly rub their eye. They have contacts and with dry eyes. They rub their eye and develop a corneal abrasion. If it's not treated, if they don't stop rubbing their eye, it actually can turn into an ulceration of the cornea, and some of those may need surgery. If you have someone that has chronic dry eyes, they need to be seeing an eye doctor to prevent corneal abrasions. Okay. If it's severe or they have a contact lens, again, you need to refer. If it's not something, take that. This is not something you're likely going to treat unless you work for an eye doctor in an eye clinic, etc. Okay. Foreign body, if you can irrigate and get it out, okay. If not, send them on. Retinal detachment, it's rare in children, but they'll complain of blurred vision. They may have a dark cloud in the visual field, flashing lights. They need to be referred. Okay. This is an eye emergency and you need to refer immediately, meaning call the ophthalmologist and say, I have a possible retinal detachment, and they'll get them in as quick as possible. Orbital fractures, they'll have pain. They may have double vision, numbness around the area, limited ocular movement. They may have a bone step off, which your book goes into more detail of. They need a CT scan to rule out any other problems and to see the orbital fracture ice. And they need to see an ophthalmologist. They may need treatment by a surgeon. Okay, they need to either be sent to ER or to an ophthalmologist. Likely, they're being seen by the ER anyway. So eyelid deformities, really all you need to know is that entropion is inversion of the eyelids. Ectropion is eversion of the eyelids, and it's very rare. Uriblepharin is a congenital anomaly. I put a picture there on the bottom of the slide. Probably not something you're really going to diagnose, but you may have a child or an adult in your clinic that has this.